Dominican Republic and moved to the US when I was very young. I grew up in Miami and got my bachelor's degree at the University of Florida, hashtag Go Gators, which is in North Central Florida. And then I moved to Minnesota to pursue my graduate degree, as Ellen shared. Believe it or not, I love Minnesota, even though I grew up in Florida. And people definitely ask me all the time why I would move here from Florida. And all I can say is that Minnesota is a great place with a lot to offer, especially for those of us who work in public health. And it's definitely not perfect, but I think there are a lot of people here that care about making long lasting change. And that's definitely motivated me to stay. And moving here has given me opportunities that I never had before, like building a snowman or go sledding. Because I can tell you, building a snowman in the sand is just not the same. And also, I don't like the heat, so there's that too. And before I get into it, I'm also going to just plug the mentorship program offered through the School of Public Health, which is actually how I met Ellen. Ellen was and still is just a really great mentor to me, and I've gained a great friend out of that experience. So I encourage anyone who graduated from the School of Public Health that has time to consider being a mentor, to consider it, and for students to sign up to be matched with a mentor if that is something you are thinking about. But that's just a little bit about me. So today I'm going to be talking about the COVID-19 Community Coordinators Program Hotline that Asera has put on over the past 2.5 months. I can honestly say this is probably my favorite project that I'm working on right now. So I'm really excited to share and hope that it might inspire others to start a hotline if that makes for your organization. And as you can see, the name of my presentation is Llamanos ahora, implementing a bilingual COVID-19 hotline in Minnesota. And Llamanos ahora in Spanish is Spanish for call us now. So just to share an overview, today I'll start off by sharing a bit about Asera. I'll share some data from NDH on the impact of COVID on Minnesotans. Then I'll share some more specifics about how we actually implemented the hotline, some evaluation findings, and what we've been learning so far. So before I dive into the presentation, I wanted to make a clarification. Throughout the presentation, you'll notice that I use the word Latine, spelled Latine, to refer to individuals with origins in Latin America, particularly those that are Spanish speaking. The word Latine is a synonym for Latinx and serves the same purpose as being an inclusive term to refer to Latin Americans, given that Spanish is a very gendered language. I personally prefer using the term Latine versus Latinx because I think it's easier to pronounce for those that are primarily Spanish speaking. And I don't want the word Latinx, which in Spanish sometimes is said as Latinx, to be exclusive of Spanish speakers. And in addition, the letter E is already used in Spanish for gender neutral terms and may be easier to incorporate into the language if we ever get to a point in which we transform the language so that it is more gender neutral. Now, that's a personal preference, but I will say that at Asera, like other organizations, we're always paying attention to our language and we aim to be as inclusive as possible in everything we do. And we're learning and growing with everyone else. And people ask me all the time, what term should I use? Do I use Latino, Latina, Latinx, Hispanic, something else? And my personal response to that is that, well, it's exactly what nobody wants to hear, which is it depends. If I'm working with young people, I might be more inclined to use Latinx. If I'm speaking with older adults that are recent immigrants who are primarily Spanish speaking, I might use Latino or Latina, or at least try to explain what I mean when I say Latine. It's certainly something that I'm constantly working on and trying to learn about. And I think it's less about the specific word and more about the context and adapting it so that all people feel included. And then you'll also notice throughout the presentation, I'll say our community a lot. And when I say that, most of the time, I mean the Latina community in Minnesota. I am Latina or Latina, and I'm an immigrant, as I mentioned earlier. So these issues are very important to me, not just because of my interest in health equity and anti-racism, but because there are issues that affect the people that I love and care about too. So there's definitely some personal motivation on my part for wanting to do this work and for even wanting to work at Asera to begin with. And if you have any questions about this, definitely feel free to put them in the chat and I'll try to answer them throughout the presentation. So just a little bit about Aser. Hispanic Advocacy and Community Empowerment Through Research, or Aser, was founded in 1988 as a collaborative effort between Ramsey County Human Services, Comunidades Latinas Unidas en Servicio, or CLUS, and Metropolitan State University. Our mission is to work in concert with the Latino community to access, generate, and disseminate credible and relevant research in order to influence institutional decisions and public policy. As Ellen mentioned, we're based in St. Paul, Minnesota, and we're currently the only Latino-led research and evaluation organization in the Midwest. And I've been working at Asera since September of 2020, so I'm relatively new, but know that Asera has made a lot of meaningful contributions in regards to research and evaluation in all the time it's been open. And even just having worked there a few months, I can honestly say that as an organization, we are true to our mission about empowering the Latino community so that our voices are heard in the hope that it will ultimately lead to improving the lives of Latino Minnesotans. And just in terms of the kind of work we do at Asera, we focus on various topics that face the Latinx community in Minnesota, including immigration, public health, which is what I'll talk about today, social welfare, education and equity, housing, community development, demographic change, economics, criminal justice, and crime prevention. And for this specific project, we received funding through the Minnesota Department of Health to be part of the COVID-19 Community Coordinators Program, which is what I'm going to be talking about today. So to start things off, I'm going to show some graphs pulled directly from the Minnesota COVID-19 response website that shows the impact of COVID-19 across racial groups. And most of this information is probably not new or very surprising, but it just helps set the stage for the rest of the presentation and the importance of our hotline in our community. So this first slide shows the incidence of positive cases of COVID-19 per 100,000 residents in Minnesota. And as we can see in the top graph, and the things that I call out, I've boxed them in orange. As we can see in the top graph, Latin Minnesotans and Native Hawaiian or Pacific Islander Minnesotans are testing positive for COVID-19 at a much higher rate than other racial ethnic demographic groups in the state. And then when we look at the bottom graphs, breaking it down by age groups, we see that this remains true for Latino Minnesotans, regardless of the age group. And again, those are the ones boxed in orange. Here, we can see that Latino Minnesotans have the highest rate of hospitalizations from COVID-19 per 100,000 residents. And for positive case hospitalizations, we see the highest percentage in Indigenous Minnesotans. So in this case, the highest is not among Latino Minnesotans. And then for admittance into the ICU, we see the rates the highest, again, among Indigenous Minnesotans, and then Latino Minnesotans are not very far behind. This graph is just kind of a continuation of the last one and shows the percentage of positive cases in the ICU. And we can see that the highest percentage is among Indigenous Minnesotans. And this time, Latin Minnesotans are a little closer to the total average, which is 1%. So we're here. It's kind of the total average. And then on this last slide, we see the death incidence per 100,000 residents. So the death rate equals the number of deaths in each racial ethnic group from COVID-19, in this specific example, of course, divided by the total number of people in that group times 100,000. So the death rate for Latin Minnesotans from COVID-19 is higher, again, than other racial ethnic groups. However, when we look at just the positive cases, meaning the number of deaths over just the positive cases of COVID-19, the percentage is actually highest among Indigenous Minnesotans and white Minnesotans. So just kind of thinking through some of the reasons this may be, especially thinking about the death rate. This could be because of the differences in relative ages of the population. So in general, Latinx are younger than other ethnic groups in Minnesota. And you'll see on this graph that only 4% of Latinx in Minnesota are 65 or older, which is much lower than Indigenous Minnesotans at 21% being 65 or older, and white Minnesotans who 19% are 65 and older. So we're a bit of Latinx are a bit of a younger population, and we know that COVID can have a stronger impact on individuals that are older. So that could be a potential reason for that. And here we have some additional context that also may factor into the higher rate of COVID cases among Latinx Minnesotans. So this visual is also from the Minnesota COVID response website, and it shows the percentage of people within different racial ethnic groups that work in different industry types. And based on these data, Black and Latinx Minnesotans have a higher risk of exposure to COVID-19. Latin Minnesotans and individuals that identify with multiple races are more vulnerable to layoffs, and Latinx Minnesotans are less likely to be able to work from home. And this graph is similar to the previous one, but it breaks down a little further by specific job types. So we see that Latinx Minnesotans are more likely to be exposed through jobs considered critical infrastructure and food production, that we are more vulnerable to layoffs in the restaurant industry, and we are less likely to be able to work from home for jobs related to education or other work from home jobs. And at the end, I'll share a Google Doc with a link to some of these sources in case you want to learn more. So these slides just kind of offer a really high level overview of how COVID-19 is impacting Minnesotans and a few of the factors that may be contributing to the higher rate of cases in Minnesota. I think it's also extremely important to note that there are systemic issues that are impacting our communities and are leading to an increase in COVID-19 cases. So this could mean the lack of availability of services in Spanish, fewer resources available for those that are undocumented, and racism that Latinx and other Black, Indigenous, and communities of color face regularly. And in addition to that, many people who live with a low income may not be able to afford health insurance or other basic needs, again, in part as a consequence of some of the systemic issues that exist. And in at least in something that might be a little bit more specific to our community is that for those that are undocumented, many times they don't want to interact with the health or government systems for fear of deportation. So, for example, we've heard from the community too that during this time, employers have been, some employers, not all employers, of course, have been taking advantage of essential workers, such as those that work in cleaning services, because they are undocumented. So maybe they're cutting their hourly pay, knowing that they might not be able to do anything about it. So there's just kind of a lot of factors at play. We did some community conversations to a separate grant around COVID-19, and people in our community, they shared just some really eye-opening experiences and struggles that people are going through. Something that was emphasized a lot was that our community has been put in a difficult position where we have to choose between, feeding ourselves and our family or exposing ourselves at work, especially for those of us that don't qualify for government benefits. And for example, I remember someone specifically that shared that their kids who are teenagers have had to get jobs in retail after the COVID started to help the family make ends meet. So now the kids have to choose between supporting the family income or getting good grades at school, which is not a decision that I think a teenager should ever have to make. So that's a very difficult position to be in. And if I'm honest, it's not something that I, as somebody who has the privilege to work from home, and who has had the privilege of obtaining a degree would have thought of unless I'd been part of those community conversations. So I think just in general, it's important to remember that it's not just as simple as, just stay home to prevent the spread of the virus, because we're not all in the same situation. And ultimately, we need to improve our policies and programs so that no one has to make those difficult decisions. So I'll pause here for a second. Does anybody have any questions? All right, I will proceed forward. So now that I've given that background, I'll share a bit about how we actually set up the hotline. So the purpose of our hotline is to connect callers to a variety of resources related to COVID-19, including COVID testing, food, housing, financial assistance, and really whatever we can connect others to. Asera, though, does not provide the actual service. So we're not a health center. So we're not providing COVID-19 testing. We're not a food shelf. So we don't give out food or things like that. Our role is really to facilitate the connection for our callers, or people in our community. And that certainly caused some confusion among our callers. And I'll talk a little bit about that later. So really, there's four main components to setting up the hotline. Building a great team to oversee the program, getting the right equipment, training our hotline staff, and building a tracking system. So here is our COVID-19 Community Coordinators Program team. It consists of Dr. Rodolfo Gutierrez, who has been with Asera since 2007 and is the current executive director. Alyssa Johnsrud and Carmen Bibiano, who are the main coordinators of the program. Alisa focuses on our southern Minnesota outreach efforts, and Carmen focuses more on the metro and central Minnesota area. And as of last week, we've hired a third coordinator to focus on the northern part of the state. And she just joined us, so she's not pictured here, but we're super excited to have her join our team so that we can really increase our reach in the northern part of the state. We have Amanda Niklaus, who is our communication and outreach specialist for all of Asera's projects, but contributes substantially to this one because there's always new information coming out from MTH that we want to make sure we're sharing on our social media pages, newsletters, etc. Then there are our four hotline specialists, Angeles, Giselle, Jacqueline, and Maritza, all of which are bilingual, have strong customer service skills, have Latino roots, and have lived in Minnesota at least a few years. The hotline specialists are the ones that are actually answering the phone calls and connecting our callers to the different resources. And then there's little old me, of course. So I won't say too much about our team, but I just kind of want to emphasize that our team, we have constant communication, and I think that's really been the key to implementing this program successfully. So, for example, Rodolfo, Alisa, Carmen, Amanda, and I meet on a weekly basis to share updates, brainstorm, and strategize around how we plan to reach more people. And in addition to that, Alyssa, Carmen, Amanda, the specialist, and I also meet separately on a weekly basis to share resources, address any concerns the specialists have, share stories of calls they've had, and kind of work through how to address some of the issues that come up and just answer questions. And then we also have a text group chat where we're constantly communicating on a daily basis. And this just really helps us address any issues that come up as quickly as possible so that they don't kind of mull in the background. The next thing was getting the right equipment, and this is just pretty straightforward. So we got laptops for each specialist and a headset to improve the quality of the audio, given that they are using laptops, so they're not using actual telephones. The specialists conduct the calls through a program called Amazon Connect, and it's the platform being used for the hotlines in this program through the Minnesota Department of Health. So we didn't necessarily decide to use Amazon Connect. The third component was training the staff. So before we hired the specialists, Rodolfo, Lesa, Carmen, Amanda, and I attended various trainings with the Minnesota Department of Health, and then passed on some of that knowledge to the specialists once our team was fully built. We trained them in how to use Amazon Connect, which, as I shared, is a phone system that we use to accept incoming calls and also make outgoing calls for the hotline. We trained them on how to use a resource database, which we created internally based on the information that MDH compiled for us for the COVID-19 Community Coordinators Program. And we built this database using just Microsoft Excel spreadsheets, so nothing fancy, though, as you can imagine, that has its limitations. We trained them on how to use a tracking system, which evolved as I received their feedback on some kinks that needed to be worked out with the actual form. And then we've offered them many other trainings that have come up. Like, for example, MDH provided one on how to ask questions about gender identity and sexual orientation. The last and also very important component of our hotline is having a tracking system for all the calls. So Amazon Connect records incoming numbers and outgoing calls by the specialist. And it also collects information like the length of time for each call and how long the specialists were online and available versus offline. And the screenshots I have here are just an example from the training that MDH offered to us at the beginning of the program. So you can see it kind of shows the answer time, how long someone's in the queue, how long the person's on hold, the length of the interaction, and then also this one shows when people sign in and out, or the specialists sign in and out for the day. So that's the kind of information Amazon Connect offers. The other way we track information is through a tracking form that we built using Microsoft Forms, which is part of just the Microsoft suite and is very similar to Google Forms if you're more familiar with that. And it's a form that has a lot of questions on it, but it helps us collect different types of information about our callers that I'll show in a moment. And with this tracking form, we really tried to make it as easy as possible for the specialists. So some of the things we did throughout were add an introduction as shown here, an introduction script and other prompts, as well as have the questions that were specific to the callers in both Spanish and English, so that the specialist wouldn't have to interpret the questions into English in real time, I'm sorry, into Spanish in real time. And it's a very minor detail, but I think it's helpful because it's just less mental work that the specialist has to do. And they can spend that mental energy finding the information for the caller. And unfortunately, some of the resources that they connect people to are only available in English. So they end up having to do some interpretation anyways. But this is just one less thing they have to worry about. Now, here we have the types of questions that the specialists answer in the actual tracking form. So the list on the left of the screen under the heading Asera questions are the questions that Asera developed to add to the tracking form to get information that was maybe not addressed by some of the questions that are part of the MDH evaluation, which is on the right. And it's important to also just make clear that the questions that are specific to Asera are not sent to MDH, and MDH does not receive any personally identifying information about our callers. So we do our best to protect them in that regard. We do ask callers their name and phone number, but again, we don't send it to MDH so that we can address them personally and can reconnect with them if a call drops or if we need to follow with them at a later point in time. Uh, the specialist will then ask the caller how the specialist can be of help and looks for the resources the caller is asking for. And then towards the end of the call, the special asks voluntary demographic questions on how the caller heard about the hotline, their race, ethnicity, their country of Latin origin, if they identify as Hispanic or Latine, length of time living in the US, and the county they live in. We do not ask callers their immigration status, but sometimes the caller does mention it themselves. because many times they already know that there will be some reasons that they don't qualify for because they don't have a social security number. And our specialists, of course, want to make sure they get connected to that individual gets connected to resources that they are actually eligible for. But again, we don't document their immigration status or send it to anybody. We emphasize to the specialists that these questions are voluntary, and if the individual does not want to answer any of them, then that's okay. We certainly want to have as complete information as possible, but our priority is ultimately making our callers feel comfortable and welcome and to give them the information that they need. Overall, though, the specialists have done a really wonderful job of being personable and friendly and connecting with the callers, which I think ultimately does increase the likelihood that they'd be willing to answer some of these demographic questions. So then, after the specialists are completely done with the call and hang up the phone, we ask them to answer a few more questions, such as which specialist answered the call. So they would identify themselves as filling out the form, which just helps us know which specialist to communicate with if something isn't clear in the tracking form, and also so that they know which calls they did. We also asked them to let us know the reason for calling. So, for example, whether the caller was asking about COVID-19 or looking for food or financial assistance. They answer what language the call was conducted in, so Spanish or English in our case, whether the person needs to be called back, and other important notes about the call and the type of call, meaning was the caller calling to ask for interpretation support at a COVID clinic that had no Spanish speaker on site, which we do offer that. Was the caller an employee of an organization that was just looking to share more information about the hotline at their own organization? Or was it just an individual or family calling to get connected to services or resources? So those are very specific types of calls. So we want to make sure we distinguish between them. So once they've answered that, we ask them to answer some more questions. And these are the ones that are specific to MDH. Um, and they're just about the type of resource the person was asking for, the barriers, if any, the caller expressed obtaining that resource, the outcome of the call, so just whether the need was met for the caller or whether they were referred to another resource. And again, the specialist does this after the call because otherwise they'd be on the phone with that individual for a very long time, and they're already on the phone with them for quite a bit. I don't have an exact amount for how much time each specialist spends on each call, plus completing the form, but I imagine it probably takes 10 plus minutes if the call is on the shorter end, and that's assuming the person maybe only has one or two questions or needs versus having multiple needs. So I'll pause here very quickly. Are there any questions?
I don't see any questions in the chat right now. I have questions,
Sure.
but I can save them for the end.
Sure. Whatever you prefer. All right. So I will continue then. So who's actually calling our hotline? So I am a research associate and evaluator. So of course, this is going to be my favorite part, sharing the fun data. So this first graph shows the weekly call volume, meaning the number of calls that we have had per week from November 1st, 2020 until midday on December 31st, 2020. So our regular hours of operation are Monday through Friday from 8 to 5:30 p.m. And we were open on the National Day of Mourning, also known as Thanksgiving, the Friday after, and on Christmas Eve. But we were closed on Christmas Day and New Year's Eve. Or sorry, New Year's Day. We were open on New Year's Eve. So the blue lines show all calls for that time period, and the orange line looks at unique calls for that time period. So the orange line is only counting like actual individuals, or you might think of it as like the first time callers, whereas the blue line accounts for individuals that called multiple times. So as you can see, we were kind of off to a slow start. which made sense given that we were just opening the hotline for the first time and we're really starting our promotion. But during that first week, we worked out a lot of the kinks with the tracking form with the specialist. So personally, I'm actually a little glad that things were slower that first week because it allowed us to learn and adapt with a little less pressure. Here we see the percentage of first-time callers for all calls, the language the calls were conducted in, and the racial ethnic identity of the callers. So we can see that about 3/4 of our callers were first-time callers during that time frame, um, and a quarter had at least called once in the past. Most of the calls were conducted in Spanish, which makes sense because that's really our focus. And most of the callers were Latino or Hispanic, which again makes sense because that's our focus. But a handful were identified as Black here, 0.4%, Native American, or white. And as I shared, our specialists do speak English. So if somebody has a need and they speak English, we are definitely ready to help them. Here we can see the Latin ancestry of the callers. So about half of the callers identify as of that were Latinx identify as Mexican or having Mexican ancestry rather, which makes sense given that the largest proportion of Latinx in Minnesota have origins in Mexico. And about 3/4 of the callers also reported being born outside of the US. In other words, that they are immigrants. And as I stated earlier, we don't ask about immigration status, but we are interested in knowing about whether the callers are immigrants so that we can see what challenges they are coming up against and to connect them to more resources that could be of use to them. Here we see the number of calls by county. So we have a really strong presence in Hennepin and Ramsey County and the metro area overall, which again makes sense given that most Latin Minnesotans live in the metro area. We do have some room for growth in greater Minnesota and are super excited about the addition of a third coordinator, as I mentioned earlier, because I think it'll really help us reach the northern part of the state since she has good connections there. So next, I'm just going to present a series of maps that I created for our internal use. And this is just another way of showing this graph that I just showed you. I created them using a free and user-friendly website called Datawrapper. It doesn't require any GIS skills, and it's a super great tool for making maps and charts if you already have spatial data. And I started developing these on a bi-weekly basis, just as another way for our team to see our reach. Since with this hotline, we're trying to reach Latinx across the state of Minnesota, not just those living in the metro area. And I'll share the link to this and again, the other resources I discuss in the presentation at the end in the chat. And what I'm going to show is just a short time frame, but as a data person, you can imagine how exciting it was for me to see this grow and expand from November through December. So this is kind of how we started off. And then slowly but surely our reach was expanding, which was very exciting, but we definitely still have some work to do. So moving on, here we see the services requested by callers. So about a quarter of the callers are calling about COVID testing, and another quarter are calling about housing, and about a third are asking for other supports. And just to kind of backtrack here, if we look at our call volume across the weeks, you'll notice that our peak calls were around the week of the 6th, which also happened to be the week of the deadline for some of the major rental assistance programs that were available. So I think that really contributed to our call volume for that week because the deadline was approaching and people had a lot of questions about that. So I think that's really why housing is up there. But just kind of going back to the graph, like I said, the greatest portion of calls have been for other support. So some of the questions that have come up in these calls are about legal assistance. We've had a couple of people ask about burial assistance. So they lost somebody because of COVID-19 and may not be able to afford to bury them. Education, so maybe they're interested in going back to school or getting a GED, or just really kind of anything. For example, during the right before Christmas, we had a couple of people call asking about whether they could get where they could get gifts for their kids for Christmas, and we were able to connect them to a few resources that did that. And then finally here we see how callers heard about the hotline. So the largest proportion of callers heard about the hotline from friends and family, and word of mouth is very important in our community. So this, at least personally, was not very surprising. Our hotline team has been very intentional about our outreach, and so far, those actions have led to calls to the helpline. So, for example, if you listen to Spanish radio, you may have heard one of our radio ads in Radio El Rey, which is a Spanish radio that transmits throughout the state of Minnesota. We post a lot on Facebook and have been using the targeted ads feature where you can like pay to boost posts. And that just has helped us expand our reach a little further. We've put ads on TV, so like the channel Univision, which is also a Spanish-speaking news channel. And we've shared our hotline information with community partners and the health department, and they've shared our number as well. And I think it's showing in how people are calling about the hotline. And a strategy that I think has been really successful is that we've had a campaign called Info Martes or Talk Tuesday. And in Spanish, it's actually a play on words because informarte means to inform yourself. And the word for Tuesday in Spanish is martes. So you get like a nice little pun. And I love a good pun. So I was very happy with whoever came up with this title, which was not me, unfortunately. But anyways, our Informartes / Talk Tuesday campaign, we have it almost every Tuesday on Facebook Live. And essentially, we invite guests to talk about various topics, including debunking what myths about COVID, information about vaccines. For one of the earlier ones, we had two young people in their 20s who got pretty sick with COVID to come and talk about their experience and how they managed that, and just other relevant and timely topics for the community that we want to share more information about. All right, I'll pause here again for any questions before I move on to the last section.
There is a question.
Sure.
Are you aware of other states or regions who have implemented similar hotline programs? And do you have a sense of callers' age demographics?
I don't know about other states. That's not something that I've looked into. So I don't have an answer for that. In terms of the ages, I didn't include that here, but generally our callers are around between the ages of, I would say 35 and 45. That's kind of where the highest proportion is. And then I would say the majority are between 35 and 65 age range.
Thank you.
All right, so on to our last
I have a question.
please.
My name is Leda, and I'm with the Minneapolis Health Department.
Mhm.
And I was curious, obviously you showed that data up to December 27, I believe. And it was right around the timing where we started with the vaccination event. So I'm curious to learn about the kind of like the type of calls you are getting regarding vaccination. And I'm assuming that number will increase as vaccination becomes available. So curious about that. Thank you.
Yeah, during that specific time frame. So most of our COVID specific calls have been about testing. So where to find a testing site in your community, things of that nature. Some questions about the saliva test, etc. I didn't look specifically at vaccine related questions or calls, but I know that even just today, and information from today is of course not shared in this presentation, after MDH announced that they've opened up appointments for for vaccines, our specialists have already been talking in our chat that they've gotten multiple calls about that. So definitely as information comes out, I do think it does bring calls to the hotline, and that was kind of just one example today. So at least in terms of our strategy, we will be focusing a lot more on the vaccine now. Before we were sharing information about the vaccine, but a lot of it was also just like COVID awareness, getting a test. But as these are rolled out, we're going to be talking about that a lot more. All right, so I'll go ahead and move on to our last section. So what did we learn? And we've learned many things so far, but I'm just going to highlight a few quick things. So something I wish we had done differently maybe towards the beginning was to provide more training for the specialists. So we only offered them a very short training when they started, and we got feedbacks after a few weeks that they would have liked more. And our training focused more on the technical aspects, so how to use Amazon Connect and how to, use programs on their laptop, how to use a tracking form. But the specialists expressed interest in training on the different types of resources that MDH compiled. And with this kind of program, it's a little bit challenging because it's not like a tobacco line or a suicide hotline where the topic is very specific. People call for a variety of reasons. So in reality, it might have been a little bit impossible to train them on every single resource available, but I think we could have done a better job of preparing them for what was out there. So kind of related to that, the specialists have really learned that it's really important to do the research on different resources so that they know what to tell the callers. It's not just saying, hey, this food shelf offers free delivery of food. Here's the phone number to set up an appointment. Goodbye, have a good day. Like it's not just that simple. And as I alluded to before, sometimes the callers call thinking that Asera directly has the resources, which unfortunately is not the case. So it is really helpful to the specialist to go into the call well informed so that they can give the callers an idea of what they need to do when they move on to the next organization to get the resource they need. So in some ways, having a lower call volume can help because it gives specialists time to look for this information. And if we were having like 50 plus calls a day, it would probably be a little more difficult to do all of that within their scheduled hours. And related to that, related just to them doing the necessary research to be well informed, the specialists have really gone out of their way to understand the barriers the callers might face when connecting with other organizations. So, for example, many organizations require a social security number for the caller to get financial resources. Some organizations require the caller to make an appointment or fill out a form online, and the caller might not have access to a computer, for example. So the specialists really try to understand the caller's circumstance and the logistical and institutional barriers that they may come across and try to work with the caller to offer some solutions to the extent that they can. And this isn't necessarily something we ask the specialists to do. This is something that they've taken on themselves and they've adapted based on the calls they've received. And I've just personally been really proud of them for just taking the extra step to prepare the caller for success to the extent that they can, because once the caller hangs up the phone and goes on to the next organization, it's really out of our hands. Yeah. Okay. The last lesson that I'll share is that helping out each individual caller can really vary in time. So if a person is calling with one question about testing sites, for example, it may end up being a quick call and then there's no follow-up needed. But if a caller is calling because they need financial assistance or their landlord is threatening to kick them out because the caller has not been able to pay rent for 4 months, or they need burial assistance but don't have a social security number. Um, Maybe they want to get public benefits through their children who are US citizens, but the parents are in the process of obtaining legal residency and may be concerned that obtaining public benefits could impact that process. Callers with those types of concerns need a little bit more time and attention. So we try to emphasize to the specialist that it's okay to not have the answer right away. And it's okay to say, hey, I don't know the answer to that, but let me research that for you and I'll give you a call back. And as time goes on and the specialists have become more informed, that's less likely to happen. But sometimes it's just important to remember to take that pause and call the person back instead of keeping them on hold, for an hour or something. And this is a challenge because the callers are distressed and they might want an answer right away. So we just encourage the specialist to show empathy, help the caller calm down a bit, and then let them know that the specialist will help them as best as they can. And then other just quick lessons learned that I didn't include in slides for, but I'll share really quickly is that just building a tracking system takes time, especially one like ours that has a lot of questions. So make sure to build in time for that and taking time to enter fake data to see if the output looks like you imagine. And it's also helpful to have a few practice rounds with a specialist during the first few weeks if you have a hotline, so that they can get used to using the phone system, finding the information they need when the caller is on the phone, and asking the demographic questions. So practice, as with anything, is key. So then the last thing I'll share is a quote from a hotline specialist about an experience that she had. And there's many more like this, but it exemplifies the impact the hotline is having on people's lives. So the quote reads, "The caller called again and I answered the phone. She thanked me for the help she received. She is pregnant and received help paying rent, baby clothes, diapers, and a pack and play. She'll get a crib when she's able to attend parenting classes. I found an awesome resource for her. It's called Guiding Star Lakota." So uh, again, I'm being a research associate. I'm not one of the specialists, so I don't have the constant interaction with the callers. But it's just great to hear from the specialists what they're experiencing. Not just the challenges, but really the success stories that they're willing to share. And we appreciate the work that they're doing for us and for our community. Any questions?
This is Leila again from Minneapolis Health Department. And thank you so much. First of all, I love this initiative. I can clearly see the impact you are having in our community. And I know that right now during COVID time, information in Spanish and in culture is more important than ever. So I commend your efforts and wish you the best luck as you continue with this. We at the city of Minneapolis have a challenge, trying to connect with our Latino community members. And I was wondering, as we build resources or we have information about specific resources that the city wants to promote among our Latinx community in Minneapolis, how we can partner with your organization to send you information that will help your hotline specialists share that information with your callers. So we're just trying to see where the community is getting information from, what resources are using, the community is using, and we want to leverage on those channels because again, your specialists are the ones that are building those relationships with callers, and we would like to help you find that information that they can share with.
Yeah. Oh, absolutely. Yeah, I think there's definitely a lot of value in having partnerships like that. Or, I mean, we rely on our community partners to also spread the word. And my contact information is here, so we can definitely talk about how to best go about that. I know that MDH has a resource list that we are supposed to pull from. So we would just have to make sure that any information you would want us to share with our callers would be approved by them first. But yeah, certainly, let's talk about that, because our goal is to keep reaching people in the community. So we want to make sure that they get connected to what they need.
Thank you.
Well, we are just about out of time, but if people have other questions, I think Carolina is happy to answer them, and you can always email her too. While people are thinking, I will say, thank you so much. This is so interesting, and it's so clear all of the work and thought and care that you all have put into this. And I can't imagine all the details trying to reach folks out, central Minnesota, which is where I'm from, right? Communities that are different in terms of internet access and transportation and how everything has been changed with COVID, and trying to reach all of them must be a lot of work, but yeah.
Yeah, I mean, it certainly is. But I think everybody on the team, we have a passion for helping our community. So we're excited and willing to do the work, and it's very rewarding. So
yeah. Well, this has been an excellent presentation. Thank you so much for doing it.
Of course, thank you for having me.
Yeah. For those of you who are not super familiar with MPHA, you can find more information about the association at www.mpha.net, which we'll put in the chat. You can get in touch with me at membership@mpha.net. We've got a lot of upcoming events that we're doing. If you're looking to join a fun committee, Carolina also is part of the membership committee.
Yeah.
And it's a great one to join. Any questions about the association, events, membership, ideas about a presentation that you want to do, a discussion you want to lead, get in touch with us, because that's really what MPHA is about, is highlighting the great work that people are doing in our community that is so important, and connecting people. So, yeah. With that, I will point out that Carolina put her resources in there. Any final thoughts or questions, folks? All right. Thank you so much.
Thank you. Have a good night.
Thank
Good
you.
night.
Well done.
Thank you.
Thanks so
Thanks
much.
so much.
We'll send an email out, Carolina, and we can include this link too.
Perfect.
Yeah.
Great
Thanks.
job.
Thanks.
I'll actually clap for you now.
Yeah. It was good. You had a lot to get through.
Yeah. Also, we're still recording. I don't know if that matters, but
I will stop.